Let's talk latency because this is a really big issue, as are dropouts. So, in looking at some additional intubation of TBI patients, we noticed that dropouts, meaning you have a loss of signal data, so you just have no pulse ox data, occurred in 79% of the patients. And that is a similar number. I think we might have been a little higher in the number of times we lost pulse oximetry data. So we're flying blind in terms of pulse ox, and we're flying blind in the periods where it's most important to know what the saturations are, i.e. before and during intubation. Well, let's talk what this latency is. Latency means that the value you're seeing on the pulse ox is actually the alveolar oxygen level from some time in the past. We don't know how long, but there is a lag between the real oxygen saturation and what's being displayed. So what kind of demonstration are we seeing? Well, if you look at where the nadir of pulse ox is, that's the low point. So if you graph a curve out, and your curve goes like, let me get you a laser pointer here, or a pen. So if your pulse ox drops down like this, and then comes up, this is the low point, all right? So that's the nadir. Let's see if I can spell this. Doctor handwriting is bad enough without trying to do it with a mouse. I think I can do this. There we go, nadir. So that would be the nadir. In 55% of the people, the intubation occurred here. Oh, I need my Apple Pencil to do this. So this is where the intubation occurred, endotracheal intubation, but the pulse ox continued to drop. Now, if you think about this, that makes sense if you understand the concept of latency. But if you think about, put yourself in the paramedic's position, you see the sats dropping, you put the ET tube in, you're ventilating, and of course, because of your adrenal glands, you're probably ventilating very rapidly, and the pulse ox continues to drop. Your natural response is to assume that there's a problem with the tube and pull the tube. So this study showed over half of the intubations showed a continual drop in pulse ox after the patient was intubated. And keep in mind, this is a study that also had waveform capnography, so they clearly knew the tube was in the right place. Latency is a big deal. All right, so all of that's bad. Let's take a look at what's happening here. So to give you an idea of where our data is coming from, this is all RSI intubation, so we're excluding cardiac arrest here. And just to be clear, DSI does not apply to cardiac arrest. All of our RSI intubations between October of 13 and January of 15. We had 86 of them, and these were the categories. So you see 22 altered mental status, 6 strokes, and 28 trauma patients, 24 respiratory patients. 86 cases. We had missing pulse ox data in 83 of them. So let me get my handy dandy calculator out here. And that is a really high percentage. So 83 divided by 86, that's 97% of all of our RSIs had missing pulse ox data. Well, is that a big deal? Well, if it's 1 second of data, probably not, but it's not. It's 6.3 minutes worth of missing pulse ox data. All right, so did we have episodes of hypoxia? Yeah, we did. And we broke those episodes of hypoxia into 2 groups, severe hypoxia and moderate hypoxia. Our definition of moderate was between 80 and 90, a pulse ox between 80 and 90. And severe, our definition was less than 80, so 79 and down. So of these 86 intubations, 73 had episodes where there was a pulse oximetry data less than 80, 79 or less. 72 of them had episodes of saturations dropping somewhere in the 80s. Well, how long were these events happening? Severe, we had 2.7 minutes of pulse oxes under 80. And we had 3.8 minutes of moderate hypoxic episodes. So that's quite a bit. When we look overall, the highest saturation anywhere during the call, so this could have been before intubation, after intubation, was 93%. The lowest was 65%. So we're seeing some pretty hypoxic patients. What was the SAT right before we began intubation? 91, 92%. Now you'll notice in our CVA patients, the SAT was never above 90. In our altered mental status patients, the SAT was never above 90. Well, what was the low SAT during the intubation attempt? In our altered mental status, 76. This is amazing. In our stroke patients, the lowest on average, or the average of all low SATs was 54%. So, was 54. Your oxygen saturation was 54%. So that's a low SAT. These patients are clearly desaturating. So we're seeing it all the time. The average low was 76. So that's a severe hypoxic episode. And we've already shown that hypoxia really hurts patients. So we need to do something other than this. And by the way, how long does our average intubation attempt take? Around 2.5 minutes. So the temptation is you see your SATs dropping. You figure, well, I can put this, I'm really good. This is going to be an easy intubation. I can get it in really quickly. And then that is going to fix all of our problems. It doesn't happen really quickly. The quickest it happened was in overdoses in 1.3 minutes. You can lose a lot of saturation in 1.3 minutes. All right, let's show some examples here. So I'm going to show a couple of good examples, and I just want everybody to be familiar with what we're looking at. This comes out of a Philips monitor, and it charts all of our second-by-second data across the event. This is our pulse oximetry data, this yellow line, and this is 100% right here. This is systolic and diastolic blood pressure. Blue is heart rate, and then, blue is respiratory rate, and we have, normally we're going to have heart rate in green, but it's just turned off on this one. So this is our respiratory rate, this is our end-tidal CO2 level. You can see where the end-tidal CO2 and the respiratory rate drop off because that's where we intubate. The patient's SATs initially are at 100, stay at 100, they drop to around 90. Now the catch is this period from here to here is a dropout. We don't know, there are no readings in between that period of time. So maybe it jumped back up to 100 and stayed at 100 the whole time and then immediately dropped down to 90. I don't know. It's probably more likely that this curve actually did this. But we don't know. Now, here we have heart rate superimposed. So this is pulse oximetry data. This is heart rate, systolic, diastolic blood pressure, end-tidal CO2, and respiratory rate. And we see our pulse ox here at 80. Presumably we're applying oxygen. The saturation gets up to 100. It stays at 100, the lowest part. So our intubation attempt actually took place over here. You can tell because the respiratory rate and end-tidal CO2 dropped off, and the pulse ox stayed at 100. So that's a very good thing. Here you notice the heart rate dropped off precipitously, even though the saturation was 100% the whole time. That's telling us this is not a bradycardic episode because of hypoxia. They were no longer tachycardic. Their heart rate's still around 80 to 90. We sedated them, so there had to have been a lot of anxiety involved here. And this was an 82-year-old with respiratory distress. This is a traumatic brain injury. Our pulse oximetry data starts off at around 95, goes up to 100, and stays at 100 throughout the event. Here was the heart rate, which was all over the place, and somehow I doubt the heart rate went from 40 to 50 or to 110 and then back around. I think we just had a lot of variability for some reason that's not real clear to me. This is our end-tidal CO2 and our respiratory rate. This is the intubation, and you can see that it did not drop. All right, so if that's the good, let's look at the bad. Traumatic injury. So we have our pulse oximetry data around 95. We begin intubating, and we drop off this cliff. Look at how rapidly this gets down. So in this patient, we had 2 attempts. Both failed. We put an i-gel in place. This is when we first recognized the patient was hypoxic. Their SATs at this point are around 45. We ventilated them back up all the way up to 55, and then took another attempt, failed at that, and then put an eye gel in, reventilated them. So it does not appear that we attempted to ventilate again in between the second attempt failure and the eye gel. And then the SATs came back up to 100. So this, in this patient with a traumatic injury, that is called doubling their mortality. Here we go, our pulse oximetry is coming along. Our intubation occurs here, and we drop off very rapidly down to around 65 and then come back up once they're intubated. You can also see that there is a drop-off in heart rate that corresponds with this drop-off in pulse oximetry. These two big numbers lines here again are systolic and diastolic blood pressure going up and down. Here's our pulse oximetry. It starts off at 90, goes up to 100. We begin the intubation. It drops down to 69, comes back up to 90, has another period where we drop down to around 85, and then the intubation is finished and it stays at 100%. This is our pulse ox data starting at 90, getting up to 100. We have another period of dropout data right here where we don't know what's happening. We do know that we are near 100 here and at about 75, 76 here. There is a very good chance that the SATs dropped a lot lower than that. If you plot out the slope coming after this, it was probably doing this. So we probably got quite a bit lower. So there's some more hypotheses. So we talked about the good, we talked about the bad. If you're a fan of spaghetti westerns, you know that the ugly comes next. So here is our heart rate, here is our pulse ox data, and you'll notice that we didn't have any for quite a while. Pulse ox is around 100. Right in here we begin our intubation. You can see the end-tidal and respiratory rate drop. It was out for somewhere in the neighborhood of 5 to 6 minutes where there were no ventilations. The patient SAT, the last recorded SAT was around 50. This is a huge period of data dropout. Then it comes back up and we were never able to keep this SAT up anywhere near where it was to begin with. The other thing you'll notice is this dropout on the heart rate and a huge amount of lost heart rate data. This is because the patient was in cardiac arrest, and this was clearly an induced cardiac arrest. This was a patient we were RSIing for altered mental status. Here's their heart rate. Here is their pulse oximetry data. It starts off at 80. We do run in, immediately go to intubation. Had a first pass success, which we normally would have said was a success, but the patient desatted to the mid-50s before we got their SATs back up. And then they dropped down briefly one other time, but basically, actually they never really recovered very well. So even with the ET tube, we were having difficulty ventilating them. Now, we all know that the way we confirm tube placement is by end-tidal CO2. Well, it only works if you have end-tidal CO2 values. There were no values in here. That's because the device was not on. There is no way we can confirm tube placement with end-tidal CO2 if we don't have it on. Please, please, please make sure end-tidal CO2 is on. Traumatic brain injured patient. SATs start off at 80. We get them up to 100 prior to the intubation attempt. We drop down to 40. That is a really, really low pulse ox. Get the patient intubated, and then they come back up. Now you'll notice there's a lot of dropouts here. There's a pretty good chance that that is just because of the way the curve works. It's probably where we were lowest. Doesn't really matter if there were anything lower than that, because 40 is just really bad. So you have this huge episode of hypoxia in a patient with traumatic brain injury. We doubled their mortality. That's not the job that we're supposed to be in. Here we have a patient with respiratory failure. SATs start in the 80s, drop into the mid-70s. We get it back up to 100. And then we do our intubation. This is 8 minutes worth of data dropout, so we don't know where this actually was. But if you look at what happened with the heart rate and how it dropped off the cliff, this lowest pulse was 40, and that was while the patient was in cardiac arrest. So we just missed all of this data. No doubt in my mind that this green curve happened because of this gold curve. This is a patient in a Poisoning or overdose, saturation was in the 70s, dropped to the 60s. We got it up to around 80. We did our 2 intubation attempts and an eye gel, and we never got the saturations above 80 anywhere in the call.